Hey guys, good evening. Let's go to part 4 of our talk today. And basically, we're going to be talking about the basics and principles of physical examination. So this is a continuation from our first couple of parts earlier. So just to go through some of our learning objectives, and we want to, after this particular segment, right, be able to carry out successful physical examinations. And this is really just an introduction to the various parts of it. So I'll cover through preparation and assessment tips for examiners. And then we want to also explore what the 4 steps are for physical assessments. And that's actually abbreviated by IPPA, or inspection, palpation, percussion, and escotation. So we also want to explore special considerations for assessing special populations, and that includes the pediatric population, the geriatric population, as well as the pregnant patients. So just to rehash a little bit, we talked about preparation for the examination, right? So one of the couple of things that we must always remember is always be prepared. And so this is the Brownies, or was it the Scouts motto? And so what we need to really be doing is to get the equipment ready. Some of the precautions that has to be observed is something that we must remember. For example, where we have patients who could potentially have some bugs that we don't want to catch. And particularly now in COVID-19, right, we've got to make sure that we have got our masks on. We've got protective gear. For example, PPE, when you are examining patients with MRSA or any sort of CREs or anything related. Get your eye protection in place, get your mask in place, get your gloves in place. And then, of course, hand washing before and after the examination. And remember that the setting for your patient, right, should be a place where it's comfortable, it's quiet enough, there's sufficient lighting, as well as privacy. So I will not try and belabor the point for the 7 steps of hand washing. I'm assuming that since we are all from the restructured hospital setting, we are all quite familiar. For the ones of us who are maybe not from the setting and are not so used to the 7 steps of hand washing, let us just go through what the 7 steps are, right? So the first step is, of course, hands to be wet with just liquid soap. Any sort of soap actually is good enough, plain soap. And so then what we do is we rub our hands from palm to palm, and subsequently the back like this, right? And with your fingers interlaced between the other fingers, swap hands and do on the other side. After that, you make sure that you interlace this and you rub the palms together this way, okay? And then interlock your fingers and rub the backs of your fingers against your palm to make sure that your fingers are clean. And then, of course, the other side as well. And then, of course, your thumbs is next, this way and this way. And then lastly, your fingertips in circular motion on both sides. Okay, so that's the 7 steps. So the CDC has already come out to say that you really just need clean running water. Running water is important, right? Because you need to wash all the toxins, whichever other infectious material away. You don't really need hot water, just clean running water. Warm or cold does not quite matter. The most important thing is that it's clean and it's running. And plain soap is good enough. You don't really have to use like antiseptic soaps or special soaps for this purpose. So some tips for examiners. Remember that when you carry out physical examination, what you're trying to do is to understand, to observe, right? And then to practice and obtain feedback on these techniques, right? So where our practical class is concerned, that's what we're going to be doing. The 3 most common types of errors include technique, the way that you do it, detection, as well as interpretation. It might be that you picked up something or didn't pick up something, and then the way they interpret sounds, particularly lung sounds, those are particularly challenging. And then recording is very critical, like we'll go through a little bit later. But if you recall, when we went through the blood pressure series, we were thinking also to write down things like when patients were nervous or when they're anxious, and which arm that you take it, and whether you could hear the last Korokov sound or not, phase 5 Korokov sounds, right? Also demonstrate some self-confidence, patience, courtesy, consideration, and gentleness. So remember that if you're in a setting like an OSCE setting and you are undergoing some sort of an exam, if you were to offend your patient or you're going to be rude to your patient and cause pain, you're going to fail right away, all right? Always remain sensitive to the feelings and how patients respond. If they are not comfortable, do not force them to do what they don't want to do. So let's go to the methods of assessment here. And we were talking about IPPA, right? So I stands for inspection, and that's pretty much using your eyes to observe what really was going on. And if you recall the first part that we were covering on general examination, right? It starts from the time that your patient enters the room. And then the next thing you want to do is palpation, and that's to use your hands to touch various surfaces to feel for lesions or lumps, right? And then percussion, just like the drum, you kind of use your drumsticks, right? So if in this setting, you would use instruments, which are your fingers. And then lastly, escotation, which is to use your sense of hearing. So these are steps to bring to sight senses of the sight, the touch, the hearing, as well as the smell into focus. And then collecting all that, think to yourself what potentially you think the patient has. Now, some of you must be thinking, "Ayo, we already got things like CT scans and X-rays and ultrasound. So why are we using our basic senses?" Now, I think it's critically important that we need to call the right examinations or the right procedures for our patients, right? Because if you don't even have suspicion, you could be scanning the person the whole body, expose them to all that radiation, and still not find anything, right? So the key idea is really just to eliminate what you think should not be the case. And then when you ever need to further investigate, that's when you send them for further imaging tests. Okay, so you would say, "Oh yeah, nowadays we hardly even observe people doing these sort of things, especially the doctors, right? These days, junior doctors don't quite do these sort of things." However, these are still good practices that we have to learn, and the basic principles of why these things are being observed. Okay, so the observation steps are usually performed in the IPPA order. However, if your patient was very young or very old, then that might be slightly different, and that's something that we're going to be exploring later. So if the patient comes with very severe pain or chest pain or something like this, then you are not going to be following through with IPPA, right? You're going to straight away call the cath lab or send the person off to A&E to be investigated otherwise. So what are focus examinations? So let me start with the abdominal examination. And this is an exception to the rule. So just now we mentioned that for most steps, right, we'll have followed the IPPA, right, procedures in that order. Whereas for abdominal examination, we do not follow IPPA. Instead, you move escotation in front of palpation. This is because when you try to palpate patients prior to escotating, right, you might actually alter bowel sounds of your patients, and therefore you don't want to cause abnormal bowel sounds that you've iatrogenically caused. So that's why you have to make sure you listen first before you start to palpate and percuss. The next group of focus examinations is musculoskeletal, right? And can you imagine, like, what are you going to be listening to, right? You have to listen to your joints. You don't quite do that. So for musculoskeletal examinations, we would usually inspect, we palpate, right? Just feel the joints, and particularly for patients with maybe rheumatoid arthritis of the joints, the small joints, you kind of have to palpate the joints to see whether there's warmth, there's swelling, and then you percuss. So remember that for musculoskeletal, right, because a lot of the patients have got maybe small joint arthritis and all that, this is particularly sensitive to you. When you palpate, you've got to make sure you do not cause patients excessive discomfort or pain. And then the last group is, of course, my favorite group, which is the cardiac examinations. And for this particular purpose, right, what are you going to palpate? What are you going to percussing for your cardiac systems, right? So you basically would inspect, you will palpate, and then you would escotate. You wouldn't be percussing anything, right? So that's why for cardiac, you skip one of the P's as well. So let's start with inspection. So inspection, right, as we mentioned in the first series of talks earlier, right, for general examination, it starts from the time you first see the person walk through the door and all the way through the whole encounter. You're keenly watching this particular person, right? You evaluate this person visually, right, in a very thorough and unhurried type of a fashion. And this whole inspection experience, right, would also involve hearing and your smell. So remember, we went through general examination, what you want to hear in terms of the way they speak, perhaps in speech impediments or smell. Remember, we're talking about hygiene and what kind of risk factors a person would have if they were, smelling of fecal contamination or otherwise, right? So all these things you're supposed to use to validate what your eyes see. Okay, so sometimes the odors or sounds, right, originating from a patient may actually not quite fit together. Okay, I'll show you an example what I mean later on. So we want to try and pick up things like patient environment transactions, like do they seem to correlate with whatever the patient is saying or what you're seeing? And the patient self-presentation, as we mentioned earlier, whether the person is well-groomed, whether the condition of clothing is well-maintained, the patient's behavior and emotion, whether they're angry, they're withdrawn, they're spaced out, patient posture, whether they're sitting straight out or not, or whether there's symmetry. I'm sure all of you have seen people that hunch over. Those could be people who have got osteoporosis and a vertebral fracture on the spinal column. And then, of course, the facial expression is very, very important because you can see whether they have got pain or whether they're indifferent or friendly, somewhat of an overlap with patient behavior and emotion. And then this last one, we didn't quite cover in the first series, but basically the presence of lesions, right? The colors, the shape, the size, whether the discharges from lesions and the location of these lesions will give you some idea what potentially we're dealing with. So all in all, everyone, we're just trying to really put together your most likely diagnosis and differential diagnosis. Okay, so let me present to you this case scenario. This is Mr. Ismail, and he's 43 years old. He's a post-MI patient, right? So because after MI, you've got to kind of be very careful about the cardiovascular risk factors and manage them really strictly, right? So the past medical history of hypertension and hyperlipidemia as usual. And he's a smoker of 20 pack years with an average of 2 packs a day prior to admission for his myocardial infarction, right? He works as a Grab delivery man. He's married with 4 children. So he arrives at the clinic with the youngest child at 5 years old. And he hurriedly tells you that he has to go off in 10 minutes to pick up his older child from school. He claims he stopped smoking since admission 2 months ago, as he was scared for his life. I mean, he's got 4 kids, right? Of course, he would have said something like this. So on inspection, he seems to have said that he claimed, right, to stop smoking. But when you actually inspect him, he smells like cigarettes and then he appears irate and frustrated. Then you kind of think about why, right? So this is an example of how when he claims one thing, you smell a different thing and you know that there's a disconnect between what he claims and what you actually observe. In the second scenario over here, we're talking about Madam Wee, and she's a 63-year-old CKD patient. She's been on subcutaneous erythropoietin since 2 years ago for her anemia. She's also on subcutaneous insulin for her diabetes since 5 years ago. She's very smiley today and she's happy to see you. She's joyfully telling you that her youngest daughter is getting married in 2 weeks' time. Yippee! And she assures you that she takes all her medicines religiously and does not miss a single dose. Oh, what a perfect patient. So on interview, she tells you, oh, no problem, I'm handling it all very well. On inspection, you detect that there are lumps on her abdomen with 2 bruises, but they seem to be healing, right? They're clustered in a 2 cm radius around her umbilicus. Now, what will you be thinking about this? Injection techniques, right? Because this commonly happens in our insulin patients, and we commonly tell them, oh, please avoid the 2 cm radius around your umbilicus, and this is how you would have injected it. So this is a fine example of how you would use palpation, right? Kind of feel around to see what has happened in the abdominal area, try to pick up the lesions that seem abnormal. And then you can feel these lumps there. And this is what we call the lipodystrophic disorders that's caused by subcutaneous injections of insulin as well as subcutaneous erythropoietin. So these are some of the examples, and they don't always present as lumps. They sometimes also present as dystrophy, like the picture over here in the corner, where you see this lady looking like she's got cavities in her abdominal spaces. And sometimes they can present with hematomas as well. I remember being in the anticoagulation clinic, and there were patients before who actually came with bruises. And they tell you that, there was no trauma, maybe they forget. And then when you actually palpate with your hand, light palpation, you can actually feel lumps there. And when you can feel lumps under the skin and there's a bruise on top of it, that is what we call a hematoma. So palpation, as you would probably surmise by now, some of you might have also even seen people doing palpation physical examination. It uses pretty much the parts of your hands, right? So the back of your hands, mums, amongst us would know to use the dorsal surface to palpate for temperature because this is the most sensitive part of your hand. And then for the ball of your hand and where the ulnar surface is concerned, right over here, you would have used it to sense vibrations. So this is commonly something you would see people do in respiratory examinations when you've got patients who breathe in and out, and they call it phragmitis. So when you put your hands on the surface of the back of the patient this way, you can actually feel some vibrations, and this could show some abnormalities in the respiratory examination. And then for the fingertips, right, and the pads, you would want to use them for fine sensations such as pulsations, like, if you want to palpate for the radial artery pulse, right? And then texture, any sort of moisture, any masses, and whether your masses are mobile, right? So this is how we've used our fingertips earlier for Madam Go, who had the lipodystrophic disorders from insulin injections. So palpation can range from light palpation to medium palpation to deep palpation. So light palpation, right, is just basically trying to put your hand slightly on the skin, particularly like, maybe you're examining near the eyes. You don't want to have to be too rough about it. For medium palpation, you may use your ball and finger pads again, and then you depress the skin about 1 to 2 cm with the lightest touch possible. And for this, you are assessing for the texture, the tenderness, temperature, moisture, as well as elasticity and pulsations and masses that could be present in the person's area of interest that you are trying to palpate. And then for deep palpation, you would depress a bit more deeper, a bit maybe about 4 to 5 cm with firm depression. So the picture on the right-hand side shows you abdominal palpation. And this is basically when you try to feel organs, like internal organs and masses for mobility, for tenderness. When you press and there's pain, remember to always pull back and always remember to ask where the pain is so that you palpate the area of pain last whenever you see a patient. So whenever you do this, you kind of want to put one hand on top of the other hand, and then this is to help you to exert a firmer pressure. And so these are things that you will be learning a little bit more during your examinations for abdomen. Okay, so always escalate palpation strength from light to deep, and all techniques are carried out in a smooth motion. Always when there's areas of tenderness or discomfort, they are always palpated last. So I shall not belabor the point by playing the video for you. So please go ahead and watch this video online. And this is going to be the YouTube link that I'm going to give to you. So the third thing that we will explore is percussion. Percussion is literally like really using drumsticks on the drum. And so there's direct percussion and there's also indirect percussion. So direct percussion is literally using your fingers to talk, 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 talk somebody's body surface area. And this is something common that people would use to examine someone's sinus spaces, okay, just to see whether there's congestion or there's tenderness. So in this picture over here, what this doctor is using is 2 fingers, and then you tap on the body part that you're interested in. And this is when you ask your patient to tell you what are painful, and always watch the facial expression of the patient for any signs of discomfort. So indirect percussion, it means that you don't really use your fingers directly on the surface of the skin or the organ or part of the body you're interested in. So basically what you're trying to do is elicit sounds that give you further clues that could give you a makeup of the underlying tissue. So what you generally do is to put your non-dominant hand at the bottom, and your dominant hand is the one that you're going to be using to kind of hit the middle space over here between your 2 joints of the finger. And for me, I prefer to use the middle finger because it's like slightly longer and it's easier to aim. And this takes a fair bit of practice. So this is another version which is a bit larger for you to see. So some people actually, for some sort of physical examination, and this is particularly for joints, sometimes we would be using the malleolus, that mallet thing. But for the most part, because we'll be learning lung examination or percussion of the lung examination through use of your fingers. And so you use your DIP and PIP space. And this striking hand actually takes quite a lot of practice. So you kind of have to use the thing, strike back and then strike here. So the rest of your hand, other than this hand that's resting on the body, should be as far away from contact of the patient as possible. And then you do a clean strike when you want to strike the part and go and then you kind of remove your hand very quickly, okay? So you don't want to leave your hand there because you can actually cause some damping of the sound. So for basically when you percuss, you're trying to listen to the type of sounds that percussion produces. So be it the pitch or the frequency, basically this will tell you whether it's maybe a very dense type of an organ or whether it's a hollow organ. The amplitude would actually be referring to the loudness of sounds. The duration of which you tung, and then you kind of like how long it lasts, that would give you a sense of whether there's any sort of vibrations or collections of fluid maybe under the particular organ of interest. And then the quality, whether it's a timbre or the harmonics or some sort of overtone, basically will give you some sort of distinctive suspicions of what the etiology of the condition might be. So this is a table where you will be covering a lot more in respiratory examinations. We're talking about different types of sounds coming from different parts of the body, and essentially timpani, you typically will hear it in the abdominal examination. But for the large part of percussions, a very fine example would be the respiratory examination, where you could hear a lot of different types of sounds like resonance, hyperresonance, and all the rest. Okay, so you hear some of these common terms like the booming, like drum-like, and flat sounds. Okay, when you percuss a patient. So this is a video on percussion, which you can watch on your own time. I'll carry on to cover the last thing, which is escotation. So escotation is really listening to the various organs, whether it be the lung, the heart, the blood vessels, and even the bowel with a stethoscope. And the setting must be quiet just so you can hear the mild sounds. Sometimes they can be very, very, very soft. And the environment should be very private just so that there aren't too many noises that can distract you from picking up abnormal sounds. The area to be escotated should be exposed as much as possible just so that you don't get any clothing. And you know that with clothing around with a stethoscope, it can cause quite a lot of scratching sounds, and then it might interfere with your listening of the true sounds that may be abnormal. So in that respect, remember that when you're also palpating for the brachial artery, when you're trying to take blood pressure, the head of the stethoscope should be as far away from the cuff as possible, just so that there isn't too much of that rubbing sound. Otherwise, you may not be able to escotate very well the sound of the disappearance of the cough sounds and then the reappearance again. So in the setting of maybe in Caucasian countries where there's winter, the standard practice is to warm the stethoscope with your hands. In Singapore, it's warmer, but sometimes I guess when we keep our stethoscope in aircon condition, like a clinic or in the office, it could be cold. And so sometimes you hear people say, "Oh, sorry, cold." The better practice would probably be to warm the stethoscope head with your hand. Okay. Remember, for infection control, that after you examine each patient, you're supposed to swab down your stethoscope head as well as the whole tubing with an alcohol swab. Okay. Focus on listening, and if you ever need to close your eyes, sometimes in a clinic setting, because sometimes your patient is trying to talk at the same time and trying to listen to lung sounds, so sometimes they don't breathe very well for you, right, or inhale, exhale very well for you. You have difficulty trying to listen to those lung sounds. As it were, even when they're doing it properly for you, it's really hard to hear. So it's critically important to try and listen very carefully to the sounds, and particularly for lung escotation, which we'll cover a little bit more later, right? You have to compare bilaterally any differences in sounds just so they can pick up abnormalities for the patient that you're examining. So the anatomy of a stethoscope, actually, very critically, the parts of a stethoscope that are critically important and common to all the stethoscopes would be this binaural assembly, which is the two earpiece on both ears. And then they will all typically have a tubing, usually a wide tubing. Sometimes you see those atas, my stethoscope having only one tube, and then those are supposed to be really expensive. And the shorter the tube, so-called better, because you can hear things more clearly. A couple of the cardiology type stethoscopes have got very thick and short tubing. The idea was to really create those sounds that are clearer for the cardiologist to listen. The other pieces of the stethoscope that's important for us as pharmacists when we examine patients is really the diaphragm as well as the bell. Okay, so the bell is the smaller surface area one, which you listen to low pitch sounds. And particularly for pediatrics, for example, when you're trying to hear heart valves, or maybe you're trying to hear the tiny vessels, you use the bell because then it focuses the sound better for you. Whereas the diaphragm is usually what we use by default, and it's like a flat surface that you use for high-pitched sounds. That's what we are very familiar with. So as you learn your physical examination, remember that you have to be turning the head of your stethoscope for the right side to be heard. And very commonly, you don't hear anything because the side facing of the head is on the wrong side. So example of low-pitched sounds include heart murmurs, any sort of bruit or venous hums, or even organ friction rubs, right? So I'm not sure whether you've actually seen like renal physicians, for example, they might want to listen to bruit of the fistulas and stuff like this. And so this is where you want to use the bell for. And then the diaphragm is where you hear high-pitched sounds. These are examples of high-pitched sounds are the lung sounds, the bowel sounds, the S1, S2 that you commonly see in clinical notes. So these are some examples of quality of normal breath sounds. And as you move from the trachea to the bronchial area and then up to the peak of your lungs, right, the epicenter of your lungs, and then as you move down, the sounds will actually start to change. And the what I call the sheng diao was like the Chinese tonal sounds for Di Shangsheng, right, the third sound of Chinese characters. They have got different types of tonal sounds, and whether it's equally pitched or there's a short pitch and then after that it goes on a longer pitch later on. It depends on where you're at for the lung sounds, and so you've got to have a lot of practice for you to be able to effectively differentiate these sounds. So just quickly, because all these things you'll be going through in more detail when you do a respiratory examination. Just be aware that where your lung is concerned, actually your right lung has got 3 lobes and your left lung has got 2. But in general, we just usually talk about upper lobe and lower lobe. So it's either right upper lobe or right lower lobe, or left upper lobe and left lower lobe. Okay. So accurate recording is critically important when you are trying to compare. So imagine that you are maybe a practitioner practicing in a COPD clinic or in asthma clinic, particularly asthma clinic, right? You've got to kind of track the clinical changes of a patient. So it's very important to record location of escotation, whether it's anterior or posterior, or the lateral surface of your chest, and the quality of sounds. I remember we were talking about whether it was rustling or whether it was vesicular sounds. You should describe it. And the quality of timbre can help you to differentiate between what the likely etiology is going to be. Also describe the location of sounds. Where is the abnormal sound? And then where do you hear it? Was it in the left lung, left upper lobe, or left lower lobe, for example? So this is a step ladder approach, or what they call a step ladder approach, is because it looks like a ladder, right, with steps, right? If you were escotating someone's chest, right, you would start first just above the collarbone, right, from left to right, and then move down, and then this way. So you should at least create 8 points on the same level on each side. So 4 on each side, and then bilaterally try to listen to the same level of the chest, okay? On the posterior side of the chest, right, remember to avoid the scapula, because you're not going to hear anything if you're going to put your stethoscope on the scapula. It's like pure bone. And then you can ask the patient to lift their arm a little bit for you to listen to the lateral side. And if you lateral side wise, you would always start from the peak of the axilla and then move to the front slightly of the 7th or 8th rib, and then after that to the back. So what we call adventitious breath sounds are abnormal sounds that you observe from lung escotation. Very commonly, for me at least, because I work with heart failure patients, we hear crackles or wheels very commonly. And this is usually caused by the small airways literally collapsing when you are breathing out, and then they're opening and collapsing. So it's kind of like sounds, right? So these tend to be discrete and discontinuous. So it's almost like someone crackling a plastic bag. And when you ask them to clear it by a cough, it doesn't go away. You get them to cough, it doesn't go away. So this would be indicative of pulmonary edema or any sort of fibrosis, because the fluids are there and permanent. You can hear coarse crackles in potentially pneumonia. So they're a bit more coarse than plastic bag sounds. And if you ask the patient to cough and it's cleared, right, then this could actually be a sign of bronchiectasis, because it's like a temporary plug. Then when you cough or you clear it with a larger pressure, you kind of hear the disappearance of the crackles. Okay. Bronchi are slightly different. Bronchi is really blockage of secretions of a larger airway. So they tend to sound like snoring sounds, not as small and delicate as crackle sounds. If you're interested to hear some of these sounds, right, you can actually go on YouTube to search for some of these adventitious sounds. They're actually quite fun to listen to. Okay. And then for wheezes, wheezes is really, can you imagine it's almost like air being forced through very narrow tubing, right? So it could be a sign of narrowing of your airways through maybe secretions or any sort of blockades like foreign bodies or maybe a lesion in the airways. And these are usually very high pitched. When you breathe out, you can hear it continuously. So you ask the person to breathe in and out, right? You can hear the and then sometimes it can be as bad, and you can even hear it during inspiration as well, and that's called stridor. Okay. And this is usually due to an upper airway obstruction, like in the laryngeal airways, right? And it could actually be like, sometimes you have got people with, say, what's that thing now called angioedema, with a closing of the laryngeal airway, got like difficulty breathing, you can hear wheezing. And then so that may be an indication that it's a medical emergency in that setting. And then there's also the friction rub. I've never heard this myself personally, but it's caused by inflammation in your pleural spaces in your lungs. And it can sound like creaking or grating type of sounds. The worst part is when you have absent breath sounds, because then it could be a sign of pneumothorax, which is a medical emergency. In other less dangerous scenarios, it could be pleural effusion. And sometimes for some of our patients, pleural effusion can be quite permanent. And so sometimes, as you do your step ladder thing, there may be some areas that you don't hear any breath sounds for. So that's why it's critically important to document it clearly, right? Because the next person who actually listens to it can actually compare that with their own notes to see whether there are any changes, right? And then if there's any areas of lung consolidation, of course, it's because of the air not being able to enter your alveolar space. Then there will also be an absent breath sounds in those settings. So let's go to special considerations for these special population people. For the pediatrics, those of us who have been mothers, you will always know that it's completely impossible to get a 2-year-old to sit still, right? How are you going to ask them to cooperate with you as you're trying to physically examine them? So we will always have to take an opportunistic approach rather than a systematic approach that's performed in adults for these pediatrics, right? So the order of examination, we might not be able to follow the IPPA kind of order, but we might have to accommodate the child's behavior. So whether the child is asleep or whether they're active, whether they're mangzang, right? Because they missed the afternoon nap because we're waiting for appointment with you. The priorities of the order of different parts of the body, right, has to be befitting in the way that the child behaves. Of course, the child's age is also important because, the child's personality, where infants and toddlers are concerned. All of us have seen some children, they tend to be very shy and very suspicious of strangers, but there are others who are so friendly, right? So again, you have to fit your patient as you need to examine them. I'm no expert in pediatrics, right? So maybe the people who are from KK can also lend some light on how they circumvent this problem. And then for the elderly patients, we got to be very, very patient with them. We basically need to remember that they may be physically challenged. And so where positional changes is concerned, we must try as far as possible to minimize giving them difficult instructions. So I remember at the wake of COVID-19, when we had to teleconference or medicine type of consult with our patient, right? I had a trainee who actually tried to ask the old lady that she was seeing, it is an 83-year-old lady with heart failure. And so she had no complaints whatsoever, no SOB, nothing. And then our friend tried to ask the patient to show the ankles. And our friend was like trying so hard to move the computer and stuff like this. And then the computer webcam fell on the floor and there was a huge difficulty. So remember, with the elderly, because they're not so nimble, there may be a limit to how much you can ask them to maneuver. So for that setting, I kind of said, if there's no weight gain and then there's no objective complaints of fluid overload, please don't ask patients to be inconvenienced this way by trying to get to show the angles, because what's next? You show the ankles and look a bit swollen or edematous. Then what are you going to ask them to do? Press it themselves and see how long it's going to take for the indentation to come back up? You can't do that, right, with a layperson. So it's kind of difficult to work with a patient, especially when they have got difficulty trying to understand your instructions and they may be physically challenged. So for these elderly patients, they may need to require a bit more time and assistance. And they may need you to also repeat a few times before they get it. Sometimes it's because of hard of hearing, or sometimes it's just reaction time issues. They may also need translation. So make sure that there's someone in the room that can speak the language that they can understand. Otherwise, they can't also cooperate with the instructions you're giving them. So they may also take a bit longer time to respond to you. So just need to be a bit more patient and spend a bit more time with them. So also remember that your elderly patient may try to be good patients, and then sometimes they will just pretend that you don't have the problem. Just like the lady earlier on who said, "Oh, I'm fine," but actually when you try to look at the abdomen, there was actually lipodystrophy present, right? So this general examination and approach to things, IPPA or whichever other order, is the same as that for any other adult patients. Just you probably need to be a bit more careful with your elderly. Also remember that some of these elderly may be pretty fragile and frail, and then they may also be suffering from postural hypertension. So again, that is the reason why we want them to minimize positional changes unless they get dizzy and they fall down. And then for the pregnant person, I'm not experienced at all, and maybe Han Hui can share a little bit about experiences in KKH. So the first prenatal visit, you want to make sure that you take the body weight of this person, and then as changes have gone by, you want to also be able to trail clinical changes. And so the order of examination is similar for other adult patients. I would imagine the abdominal examination is not the same because you can't really palpate the deeper organs in the abdominal space. But also special attention needs to be paid to the diagnosis of pregnancy, be it the assessment of pelvic adequacy or whether they could hold the baby in. An assessment of the fetal growth and well-being is also critically important for your pregnant baby. Okay, with that, I have completed the quick series on the general principles and approach to physical examination. So I hope that next week when we come back and we physically do blood pressure on one another, take pulse and all, we'll be a bit more well prepared and you have a little bit more knowledge to make this go well. All right, thank you very much and thanks for listening. Bye.